Invite Dr. Ramamurthy on concepts of Contoura.
This is going to be a fairly basic talk where I am going to introduce you to the concept behind Contoura vision. There are two major horses which we face today. One is the Contoura vision, another is smile. What exactly is we have different treatment profiles in laser vision correction that is available to us. Plano scan, wavefront optimized, wavefront guided, topo guided, custom Q ablation. Over the years, all of them have found a place in our armamentarium as far as laser vision correction is concerned. When we started out in laser vision in the early 2000s, wavefront guided was the one which attracted maximum attention, where we used to customize our treatment apart from the refractive error on the aberrometry values. The basic premise was to calculate the amount of aberrations that are pre-existingly existing in the eye and try to correct them. The concept was not to prevent induction of aberrations, to correct the aberrations which was already existing there. We were not considering the Q value of the cornea or the peripheral corneal aberrations. And essentially the interest in wavefront guided ablation, the concept of supervision, 6.2, 6.3 vision, etc. went out of the window. And we all realized that more than the quantity of vision is the quality of vision is most important. Then came the concept of wavefront optimized treatment, where we are customizing laser treatment based on the unique keratometry and refraction values, where additional pulses are placed in the periphery of the cornea, where the effectivity of the excimer laser pulses is somewhat deficient, so as to end up with a fairly smooth regular cornea at the end of the treatment, irrespective of the amount of refractive error that you are treating. So that's what is called the aspheric ablation. And here the concept was not to correct the pre-existent aberrations, but not to induce aberrations during the treatment per se. And this is the one which has stayed with us now, and most other platforms that we have built today is based upon this. What are the advantages of wavefront guided over topo guided? Basically, in wavefront guided treatment, what we are essentially doing is to do the treatment on the surface of the cornea so as to smoothen out or flatten out the extremely steep cornea. If the cornea is like this, we are going to ablate only this portion of the cornea so as to smoothen it out and bring it of a uniform shape. But on the other hand, when you are talking about a topo-guided treatment, it's a bimodal treatment where you're not only treating the steeper part of the cornea to flatten it out, but you're also treating peripheral to the flatter part so as to steepen this. Because of this, the amount of tissue that's consumed by the topo-guided treatment is far less than the wavefront-guided treatment. This is the way, this is just to explain this. This is the flatter part of the cornea. This is the steeper part of the cornea. This is the ablation profile where you directly ablate the steeper part of the cornea, and the ablation is applied peripheral to the flatter part of the cornea so that you end up with a fairly smooth cornea. The concept is not to correct the refractive error completely, but to smoothen out the cornea to improve the best corrected visual acuity. That was the concept of the topo-guided treatment, which has been available to us right from 2003 as a repair tool, and we ourselves have been using it for more than a decade and a half. So what are the advantages of the topo-guided treatment? Unlike wavefront aberrations, the aberrations on the surface of the cornea, which contribute to totally almost 90% of the total aberrations in the eye, are static. They are reproducible. They don't change with time. They don't change with accommodation. They don't change with aging. And we are able to get almost 22,000 points from the entire surface of the cornea. And based on this, based on the treatment on the corneal surface where most aberrations are situated, we treat. This is not affected, as I said, by age, pupil, size of the lens opacity, etc. More importantly, we take into consideration also the asphericity and the keratometry values. And the treatment is not centered on the pupil, but it's in the corneal vertex through which the patient actually sees. Inherent to Contoura vision is also cyclotorsion compensation and pupil centroid shift. These are the basic advantages of a topo-guided treatment and per se for the Contoura treatment. Why exactly Contoura came into being was that when topo-guided treatment was already widely in practice in Asia Pacific and European region, Alcon went to FDA for approval of their topo-guided treatment for irregular corneas. FDA said if you're going to apply it to irregular corneas, first prove it to us that it's going to function quite effectively on regular corneas, and that's the reason this particular trial was started, where virgin untreated corneas were taken up for treatment using the topo-guided concept. So basically, the inputs for this particular treatment comes from either Placido-based systems like the Topolaser Vario, or the Pentacam can also be the oculizer or a Pentacam. The Scheimpflug-based systems are not really useful this particular treatment. So the basic premise of this treatment is essentially the refractive data is taken out, and then you get the topographic map from the corneal surface, and both these data is combined together, and the EX500 or the 400 used for exactly treating the surface of the cornea to regularize it. So this is the topographic map. This is the ideal topography that we are trying to get, and this is the difference map. This is the ablation for correction of the higher aberrations that is needed. This is added on to the refractive data, and thus generating ablation pattern that needs to be applied on the cornea. In short, this is the manifest refraction of the patient, and this is the height data of the higher order aberration that's there in that particular cornea. These two are combined together. As you can see, the treatment plan is quite similar to what it would require for a treatment of the manifest refraction alone. That's because the higher order aberrations per se in a normal cornea only requires a minimal amount of treatment. This is the left eye of the same patient, demonstrating a similar concept. So what are the features of the Contoura? It corrects both the sphere and the cylinder, corrects corneal irregularities. Mind you, these are virgin corneas which have a good visual potential. So these corneal irregularities are not too much. Minimizes induction of spherical aberration because it's a wavefront optimized platform. Cyclotorsion compensation is inherent, centered on the corneal apex, because of which when you are talking about run-of-the-mill corneas or run-of-the-mill refractive errors, this seems to have all the good points in it. Corrects both the sphere and the cylinder, corrects corneal irregularities, minimizes induction of spherical aberration. So topography, so what the FDA study showed, that was which was conducted in 9 centers, that out of the 212 subjects who were taken up for treatment, where up to 9 diopters of myopia, 3 diopters of astigmatism was treated, the results were extremely encouraging. In the sense, almost 30% of the eyes gained 1 or more lines of post-operative uncorrected visual acuity at 3 months compared to pre-operative. Basically, these patients were cherry-picked so as that the aberrations were not too much. But this was the only treatment that had so far shown an improvement in the uncorrected visual acuity compared to the pre-operative best-corrected visual acuity. Almost 90% of the post-operative best-corrected visual acuity was equivalent or better than pre-operative best-corrected visual acuity. And 40% gained 1 or more lines in post-operative best-corrected acuity compared to the pre-operative spectral corrected visual acuity. We have been using this platform for almost 7 or 8 years. Here I just present you our initial study. When we did a Contoura eye study, we ourselves are not too enthusiastic about this Contoura platform initially. But then what it showed was 100 patients, 1 eye treated with wavefront optimized, 1 eye with Contoura, and 100% of the eyes undergoing Contoura had a postoperative residual spherical equivalent error of less than 0.5 diopters. On the other hand, the results were equally good with wavefront optimized, but is in the range of about 95%. And mimicking the FDA study, 30% of the eyes undergoing Contoura had more than 1 line improvement visual acuity. And the amount of induction of aberrations as far as coma and trefoil was concerned was much less with Contoura compared to wavefront optimized per se. Thank you so much for your kind attention.